Good afternoon and welcome to the Assembly of Osteopathic Graduate Medical Educators, or AOGME's webinar on holistic and novel approaches to residency recruitment. My name is Alenta Long, Executive Director of AOGME. We're very pleased to have Dr. Chrisman-Khawam, Dr. Harley, and Dr. Snyder as our featured speakers today. To learn more about AOGME, please visit us at acom.org/AOGME. Before we get started, I'd like to go over a few housekeeping notes. This webinar is being recorded and the recording will be posted on the AOGME's webpage. All webinar participants are now in listen-only mode. If you experience technical issues during the webinar, please use the chat feature and raise your hand and we will assist you. If you have questions during the webinar, please feel free to submit them anytime through the Q&A feature. If time permits, questions will be addressed either during or at the end of the presentation. I'll very briefly introduce our speakers today. Dr. Leanne Chrisman-Khawam is the Director of the Transformative Care Continuum at Ohio Heritage College of Osteopathic Medicine in affiliation with Cleveland Clinic and Assistant Professor of the Department of Social Medicine. Dr. Douglas Harley is the Program Director of the Family Medicine Residency at Cleveland Clinic, Akron General, Clinical Professor at Ohio University Heritage College of Osteopathic Medicine, Vice Speaker of Ohio Academy of Family Physicians, and Board Trustee of the Ohio Osteopathic Association. Dr. Sandra Snyder is the Director of Medical Education and Program Director for Cleveland Clinic Family Medicine Residency. Dr. Snyder is currently serving as the chair-elect on the AOGME board. We're very grateful and pleased to have our speakers with us today on this very timely and relevant issue on residency recruitment. And now I'll turn it over to Dr. Snyder.
Hi, I'm Dr. Sandra Snyder, and I'm here today with Dr. Leanne Chrisman-Khawam and Dr. Doug Harley. We are pleased to be with you this afternoon to share with you our holistic review from an undergraduate medical education perspective and how we used what we learned from this process and are applying it to our graduate medical education process. With the announcement of the USMLE Step 1 going pass-fail, having some students missing some of their level 2 scores, and interviewing post-COVID on a virtual platform, we thought this would be a perfect time to share our educational community, our work. These are our objectives. So we want to describe to you the transformative care continuum in our recruitment process. We want to demonstrate some recruitment tools, and we want to elucidate early outcomes. A little bit about why we completely overhauled our recruitment process. We think both pre and post-COVID, we are not training physicians, especially in primary care, to meet the needs of our patients, communities, and societies as a whole. If you need to change the output of medical education, you need to change the input. We thought to look beyond our traditional measures of excellence, grades, board scores, and find other metrics that we could screen for that would make them better prepared for our ever-changing medical world. What metrics do we go after? Metrics we feel that would make them better future osteopathic population health physicians. These are our pioneers. These are our first class of students who are now in their third year of medical school, who have already matched into our family medicine residencies at the Cleveland Clinic. And in a short 8 months, these pioneers will be our interns. The Transformative Care Continuum. This is a joint venture between the Cleveland Clinic and AOGME. In this venture, 8 out of our 17 GME family medicine slots are used for our UME-GME continuum. From day 1 of medical school, the TCC places medical students 1 day per week in 2 of the Cleveland Clinic's family medicine residency clinics, either the Lakewood Family Health Center or the Akron General Family Medicine Residency. This is a 6-year UME-GME continuum where they complete medical school in 3 years, and we received an NRMP exemption, so they automatically are matched within our residency clinic, and they are all guaranteed a job within the CCF healthcare system. Our recruitment team consists of members of both UME and GME. Our GME team consists of faculty, behavioralist, and a resident. We actually have the same recruitment team and the same set of questions, and we use the same evaluation rubric. We collaborate as a team and standardize the process. We have a smaller team, which is often a larger time commitment, but we actually have more consistent results. Screening. How do we screen applicants? So we start with essays. We actually have our people applying fill out essays about Northeast Ohio connection, underrepresented minority, and primary care. We review their letters of recommendation. We also do SJTs, which are situation judgment testing that Dr. Chrisman-Khawam will talk further about. We adopted these from human resources work, and we actually switched it into clinical and educational scenarios. We do screening surveys, and we picked surveys that match what we would want future primary care physicians to be versed in. So we do tolerance for ambiguity, and this is basically their comfort with the unknown or uncertainty. We do Groningen's reflective ability scale, which helps to evaluate how they register emotion in others and self, their self-reflectiveness. And we also do the Jefferson empathy scale, which covers compassion, altruism, and confidence versus narcissism and aloofness.
Thanks, Sandy. As we really look at our applicants, every applicant really is here for the same thing, to get into medical school. What we're looking for is a team that will encourage and drive each other to build each other up. As educators in this model, we don't need to solely focus on each individual, but engage in the broad stimulation of this group of extraordinarily self-motivating individuals. They push each other to make each other better and those around them, thus making us all into a better team. Let us walk you through what we look for in those team members, and we'll engage each other. These also represent some of our strategies to help reduce and neutralize implicit bias. First, we examine extracurriculars, things like leadership experience, the duration around that, community service, awards such as Gold Humanism Award or service awards, and then any research that they've done. We look at the distance traveled. This is stuff that we can find in their personal statement or their MSPE. We value real life experience, whether it's in their family, in work, in life, and all of those things. We're looking for those individuals that maybe have gotten knocked down, but were able to get back up. We look for those that have found their resilience. And now for some of the finer details. These are some of the items we score as we go through the process. A quote attributed to Theodore Roosevelt sums it up perfectly. People don't care how much you know until they know how much you care. In this type of relational environment, trust is primary to the success and trust is primary to its success, and individuals demonstrating those traits, the traits that we just talked about, are our secret sauce. Holistic review must be intentional, disciplined, and mission-focused. We value those unique experiences that expose learners to different socioeconomic individuals or individual experiences with social determinants of health. We value the unique experiences that require hard work or appreciation and exposure to other cultures. We evaluate those that grew up in a culturally diverse family, whether it was part of their own family, they married in, or it was the neighborhood in which they were where they were raised. The key is finding what works for your program and for your institution. Dr. Martha Elks from the Morehouse School of Medicine asks us to think about academic preparation viewed broadly, thinking about the person, not just the stats. Looking at the foundational attitudes of professionalism, evidence to the commitment of the mission of the organization, meaningful service activities, engagement with the underserved populations. Those are the things we're looking for. So you might ask, what about test scores? How do those factor in? We certainly need to look at these scores viewed in context, but is there a threshold effect that may limit the application review of somebody that is going to be a good doctor? Because what do test scores really mean? Scores predict scores, not necessarily the academic outcome or performance as a physician, nor does it really predict their functionality on a team. They can give us the baseline level of applicants as we go through the review, but we really need, as we're hopefully demonstrating to you in this presentation today, that they need to be viewed holistically in the broader context, looking at those traits that we talked about and that we alluded to earlier. This allows the scores to be interpreted in the context of the overall student's profile. What we are looking for is evidence of growth and not necessarily the base raw scores. Disparities in medicine are currently front and center if you've been paying to the news or your news feeds coming across your phones. Current standardized testing in and of itself assumes that all test takers have equal access to preparation environments or resources so that we can really look at apples versus apples as opposed to apples versus oranges. The tests themselves sometimes reflect some intuitive bias. If we look at personality trait of the INTJ, those are the ones most likely to write the questions. So individual test takers with an INTJ personality are really going to match up with the questions and do much better. We're doing a lot better at getting teaching to the test as opposed to teaching the knowledge that we need to make a good doctor. You know, I think if you reflect back on this to those that are listening on this presentation today, that if we simply looked at past test scores, most of us might not be able to get into med school at this time in our lives. But does that make us inadequate doctors? No. This is why we need to start to rethink about who and how we admit those individuals into our fold of doctors.
Thanks, Doug and Sandy, for your many contributions to both our talk and our admissions processes. So this slide shows a summary of some of our results, again, into an undergraduate medical education program that is also admitting into residency. We receive at Ohio University Heritage College about 6,000 applications every year, and of those, about 600 apply to TCC. We screen for those whose geographic background and or commitment to family medicine in Northeast Ohio match our own. We then apply these multiple surveys about which Sandy gave you a little snippet, including the tolerance for ambiguity test, which really is testing for that comfort with uncertainty, very necessary to family medicine. Reflective ability, as she mentioned, as well as situation judgment, where they are exposed to moral quandary that test their core beliefs. And they are then asked to write a short, few sentences essay about why they chose the answers they did and what core value was driving them. Additionally, of course, the Jefferson Empathy Scale, looking for their empathic ability and professional identity. We're less focused on GPA and MCAT and a focus, as Doug mentioned, on growth, resilience, and distance traveled. So those that have that gritty drive and commitment, as well as the service focus, tend to be better long-term candidates. And they do better with both quote unquote failure and the failure associated with system changes, quality improvement, and process improvement, one of our core missions. They're also better at sustaining effort through their own challenges and the challenges of competing clinical and systems change, as well as population health work, something that is core to our curriculum. They must pass both that core education that all medical students are doing, as well as participate in the community and in their individual clinics. So we look at these initial screen results of approximately 600 applications, and then we further narrow those through the applications process in conjunction with our admissions team. We then interview approximately 40 for our program and select just 8, but many more are admitted to the traditional program at the medical school with about a 55 to 78% acceptance. And I just show you, just to highlight some of the findings here. You note that the undergraduate science GPA is significantly lower in these students than we would traditionally take. 322, this last year, 327 back in 2017. But what we looked for was this sort of growing improvement. So some of these folks had a little hiccup or one class or a few classes that were really tough for them, but then they came back and overcame. And some of them also then went on and took graduate programs, and you see those graduate GPAs significantly soar compared to the undergraduate ones, and similar findings in their total GPA. The other thing is that we've taken, on average, a lower GPA or a lower MCAT score than the school at about the mean, about the 50th percentile. It's gone up a little in the past years, but what that doesn't show is that average deviation of about 11 points, which means we have some folks that have much lower MCAT scores to start. If you look down at the bottom, under grades, we see that everyone has done above the average or mean, despite some of those kids having much lower MCATs in the lower third quartile. They are now in the top 20% in terms of their class grades. And I think what that reveals is that this grit that we're talking about is a real thing. And so what we've been really lucky to do is to find those diamonds in the rough and really mold them into the real diamonds that they can be. The other thing that we're really specifically focused on is recruiting a diverse workforce pool. So this doesn't necessarily mean that all the students are underrepresented minorities, although that is a goal of ours specifically. We have not always been successful, as you can see in 2019, in identifying and achieving that. Our first class had 3 Black students. Our next class does have a lot of ethnic diversity as well. We see other diversity in the class, including older students, some that have come with other kinds of careers and experience, and folks that were even refugees. We also have a little higher average age than the rest of the traditional class. You can see already this year, we're doing pretty well on those metrics. Sandy's excited, which you can't see, but she is.
Very.
So the unique characteristics that we're looking for are people that are going to remain dedicated to underserved populations and communities. Those that are interested in underserved medical specialties like family medicine, psychiatry, and things that we need to have more robust population health. We also think that it's important to have strong leaders. Leadership experiences can be very helpful in promoting someone who will in the future have to lead a team and work in a communication style with other interprofessionals and new learners as well. We think too that life experience makes them more gritty, and frankly, those who have suffered in some sort of way, and for sure socioeconomic status, that if they are from that neighborhood, that maybe they'll go back to that neighborhood. So that is another thing that we have noted to be helpful. We also have 1/3 of our current cohort who are AmeriCorps scholars. We have many who have global health commitment, and we have at least 2 National Health Service Corps scholars as well. Gender is important to us in terms of diversity, and we even have LGBTQ individuals who have a commitment to that community and those vulnerable populations. Another thing that we're looking for is maturity, and sometimes prior healthcare experience can bring some of that. Strong communication skills and commitment to a proven commitment to underserved communities and underrepresented minorities. So some of what can be useful is to look at judgment. So what kinds of decisions might they make in cases? So we've come up with a number of these situation judgment tests. These have all been modified from human resources situation judgment tests that have been validated, as Sandy mentioned before. And it basically exposes them to a situation where they're going to have to make some decisions. And there may be a moral quandary or a degree of professionalism or scope of treatment that they need to decide on the spot. So this one was taken directly from a human resources case in which a mother is expressing anger about something at a retail store. And then the answers were also modified simply to place them in a medical context. So this is one that we have done. And then the student in a timed way is asked to drag and drop those responses in a ranked fashion. None of the answers are ideal. So you have a bit of moral quandary here because none of them may be exactly what you do. And so we're trying to get a sense of what they think is most important, least important. And you can see here there's a pretty good breadth of answers. And this is what we're looking for. And some of these really represent a degree of dismissiveness and some represent more empathy. Some are out of the scope of what a student should be doing. And so all of this is in here, and you'd be surprised how often they think they should be out of their scope of practice. So those are used as screening, and then we have formulated the interview day. And we've found that during the time that we've been doing this, students are doing remarkably well, and this is translated well to the virtual environment. And I think because we've had years of practice, we are using these same behaviorally rooted questions, 8 to 10 behaviorally based questions per interviewer across 8 interviews. Now, I know this is probably not what you're doing in your GME day, but I think the point here is that these kids that we're taking in are both interviewing for medical school and for residency. So there's a little more hoops to jump through. Still, there's really something to having the same set of behaviorally based questions that are done across interviewers consistently so that everyone gets the same chance to answer those questions. And again, the questions fall into categories around resiliency, grit, empathy, compassion, looking at that big 5 or NACE, the narcissism, aloofness, confidence, and empathy, or sometimes called the big 5, that's been studied around long-term care and the success with patient outcomes. We also look at these more broad categories related to teachability, achievement drive, cognitive drive, authoritarianism versus self-motivated, and comfort with ambiguity and uncertainty, optimism and the ability to self-reflect and see emotion in others, narcissism versus empathy, and aloofness versus confidence. We also kind of look for conflict management, maturity, and this thing called discernment, meaning the way that they say things is also consistent with how they act. We also look for this commitment to primary care, treatment of the underserved, and we use questions like, tell me about a conflict you've had with a supervisor. With a push question, how did you handle that situation? Can you think of times when you might be the person in charge? What did you learn from the situation? Or tell me about a piece of feedback that you've incorporated into your work and habits. So we're continuing even through our questions to re-emphasize the mission and goals of our recruitment throughout interview season. In addition to the concept of behaviorally based questions and SJTs, another virtual opportunity for GME screening comes out of my previous experience as program director, where we had an interview day case. So this is a case that's videotaped, and you include some introductory instructions at the beginning of the video so they know what to expect and what's coming. We used to also send in the letter that this thing was coming so that people could be prepared on the day. you'll want to create a case with an adequate breadth to assess your desired mission goals for your program. When we did this, it was pretty difficult to get the case all videotaped in one take. So we had to edit it and didn't do it all in one take. And then we'd edit the resident interviewing the patient with soft fades in and out of the interview. So you'll construct a case that includes that breadth of information, offers a very broad differential, and includes elements you want to see in your future resident's address. Within our case, we had elements of substance use for self-treatment of depression, social determinants of health, including food insecurity and transportation problems, an association with intimate partner violence, a high ACEs score, and risk for cardiovascular disease, PE, pneumonia, and even pancreatitis and cholecystitis, with a need for acute mental health intervention and possibly a spiral CT. So you show elements of the examination, and whatever you can't show, you can have the resident report out to the attending. After this, the attending will turn to the camera and prepare them to plan a SOAP note and to precept with one of the faculty members. What's great is you get a breadth of skill across that precepting interview, quote unquote. During that interview, some will focus on the acute diagnosis and spend time discussing the right kind of test to do, spiral CT versus D-dimer and a VQ scan, and what those sensitivities and specificities are. Some will talk about how best to anticoagulate if positive. Some will miss all that and go straight to substance abuse and suicidality, while others will focus on intimate partner violence. We aim to leave them with what is most urgent and how important follow-up and long-term engagement would be around these oft-missed issues. So importantly, as you decide what you're going to cover in a case, it's important to highlight the things that are important about your program. Give clear instructions about the content. Over the next 30 minutes, you'll view a case about 10 minutes long. You will write a SOAP note, and then you'll precept the case with one of our preceptors. You'll discuss your differential and consider therapeutic options. The idea isn't to be perfect or right, but to precept the way you would in your next job as a resident. So our key takeaways here to workforce development are to help reduce health disparities by transforming the physician workforce. We're only going to do this if we get diversity in our workforce. CDC evidence has recently come out, I'm sure you've all seen it, revealing improved life expectancy if you're cared for by someone who is the same ethnicity of you. What's that related to? A lack of trust, maybe. Implicit and explicit bias, probably also related. Maybe it is partially because we don't understand the experiences of our patients. The data is not yet clear, but what is clear is that we need more Black physicians to take care of our Black patients and Hispanic physicians to take care of our Hispanic patients, and for all of us to become more culturally sensitive, which will happen more naturally as we rely on collective we of the trainees that are learning and working together. So this makes most of our points, and I think one of our other points is that we just have lower numbers of African American applicants, especially men. So one of the other things that we need to do, including this look holistically, where we're not just looking at the numbers, but are really looking at individuals and their growth potential, we also need to look at the pipeline and support those students that come behind. First medical students, pre-med students, high school students, and frankly, middle school and elementary students. We know that education supports are not adequate, and after this pandemic, things are going to be a lot worse. So that's our talk, and I think we're going to turn on our video and answer some questions.
Wonderful.
Yeah, so we have, I guess I'll leave this off for now. We have some questions that were submitted ahead. What will be the biggest challenge for virtual interviews? And I think we've all experienced IT difficulties, just like this is somewhat difficult. Wi-Fi connectivity is actually one of the big challenges. And you're gonna have to prepare for failure. As your students or your medical students who are applying for residency or online, I would just anticipate that there are going to be times where they get cut off, and make a plan for that ahead. That is one real potential risk. I think eye contact is another. We're struggling with that now. I'm supposed to not look at all of you, but at this dot on this screen, which is difficult for people. And so you may lack that sense of connection that you previously had with applicants. I think that's a real risk. There's also the loss of the candidate sense of what your program feels like. So the more that you can have informal chat times with existing residents or games or those sorts of things, the better. Here's one. What are best practices for AOGME, GME programs considering incorporating into their recruitment process? Sandy, you want to take that one?
Yeah, so I mean, I think some of the best practices we shared here would be, I think that CASE is really a good tool. If you kind of assess what you're looking for in future candidates to develop a case in the virtual world, I think is a good tool. I think behaviorally based questions are, and especially if you have consistency across all interviewers are, some of the tools that I really think. And then, the SJTs, I've really, looking at them in the UME world, I've really enjoyed them, and I'm really thinking of starting to use that more in the GME world.
We were also asked, Russell, thank you for that question. What if the student changes their mind on specialty choice? Within this program, we have an opportunity to actually off-ramp them into the regular 4-year program. So that's a real benefit, is we kind of have a plan for that. And then we would pick up an additional student in the match for the following year. Within our NRMP exemption, we have the exemption for a year at both sites, but they can put that student back into their match if they need to.
And I think when we actually screen these students, we really focus on their exposure to primary care. So we ask a lot about that. We look specifically at how many hours they volunteered in primary care. And so if we find that they lack that, we often will, if they're very interested, encourage them to get some exposure to primary care and reapply. Because we know there's, committing to a specialty very early, and that's often hard to do. So having some exposure to that really helps that piece. And we've, so far been successful with that route.
I think the hard part is no matter what happens, you're always going to have the potential to have somebody drop out of the program and move in. So I think that's been something that we've been aware that may happen. We have not had it yet. But as Sandy was saying, really the big piece is trying to tease out, both in the personal statement and the letters of recommendation and volunteer and even work activity, who has the heart for family medicine, who really has the drive to be going that route. I mean, there's always going to be that potential change over the 3 years, but this really helps to kind of minimize that potential for that.
And Russell also wants to know, what's the agreement with the NRMP on students going straight into a residency and not entering the match? So do you want to take that?
Yeah, so if you go to the NRMP website, there are a couple ways that you can get an exemption in, and one of them is a family medicine accelerated pathway. And you just have to, prove that this is a longitudinal piece. So we applied when we initially started this program in 2018, and they asked pretty detailed questions to make sure that you truly have an accelerated pathway. And then we actually have every 3 years, we have to reattest. So we initially applied in 2018. So this year we actually had to fill out our attestation. And what you actually do is just document the progress of these students and where they are, and they just track them to see. And they're really looking, for what you actually asked, Russell, is that they're looking for the opportunity for these students to opt in and out. So, and us too, like if we feel, somebody might need a 4-year program versus a 3-year program, we will counsel them because we really want the best interest for them, because, this is, they go all year, and instead of having study time, they actually will have clinical time and pop health work. So it is, a big commitment. So it's just, we make sure that that's clear when we set up that agreement.
Great. So you also asked how the institution found the resources for the intensity of the initial interview process. And so a good deal of that was one, our AOGME process. We have a large admissions committee, and they collaborated with me to create something that was more holistic. I had an interest in that already, and so that was something that they put some resources behind. So the medical school, and I would say we then all came together. So it really comes from how much heart and effort our 2 program directors and the program director before Doug put into this process.
And I think that the neat part about this is actually letting GME be involved in UME. And initially it was a lot of work, but we're actually at that point where we're going down in the number of candidates in the residency. So we actually are interviewing less in the residency because half of our class is made up of these students. So now we actually we've already done kind of our GME work in UME, so now we actually have less interviews and less work. And it's also, I think, been very beneficial because it's given us more courage to try some of these tips and tricks we've learned in UME. And I think both Doug and I are proud to say that our residencies, and including the TCC students, really reflect the communities in Northeast Ohio that we serve. And I think if, we have been part of kind of this recruitment process, despite initially it was a lot of work, it's really paid off dividends for us in our diversity of recruitment, and also just we have to spend less time. And we also get to trial, like we've been through, we've been interviewing for the UME since September. So for us, we've kind of gotten our kinks out, and now, we start next week for GME, but we feel very confident because we've worked through UME.
And I would just say, in terms of that workload piece, there is another benefit to having these students in the program. They are much more pliable to change. And so they are really helping us change culture within the residency programs around things like population health and quality improvement. We're just seeing a big ramp in terms of the things that they can do to actually help the programs achieve some of the outcomes that they would like to. And I think too, as Sandy mentioned, there really is something to getting the kids from Northeast Ohio who are from the community, who want to stay in the community and work in the community. It's like we're also working on our attending recruitment too. So there's pluses all the way across in terms of working together. And I mean, I'm an extra person that gets to work in the residency, and I have help also with the students. So it's remarkable kind of give and take, and it's great to have a good team too. That makes a lot of difference.
Yeah, I think one of the other pieces too was the larger institution. Leanne had mentioned about Ohio University Heritage College of Osteopathic Medicine, with their buy-in to the program, really looking at it. But I think the other piece of it is the Cleveland Clinic realizing that for population health in Northeast Ohio was a huge thing for them. And this represented a way to be able to advocate for that, but also to improve the diversity of students that are coming in through medical school and residency and then going to be out in practice within the Northeast Ohio area. So I think really having an institution that is supporting behind it, I think that answers into Russell's question as well, is I think from our standpoint, we have the buy-in and we really want to make sure that we're providing the most support for our students on the UME and the GME side, but even having those that employ us having that responsibility and desire to see that through has also been a big thing, because really adding this program into the process not only has changed the way we interview, but has also changed the way we give medical care to our patients, and really looking at that population health and how we can be involved in the community, providing community service, quality improvement projects. So really all of those things have matched into additional dollars needing spent by the host organization because of the added expense, but then looking at the dividends that are going to come down the line from that.
And Olivia, how are you, my friend? You also ask about good UME, GME collaboration. Can you share some informal and/or formal feedback from TCC students about their curriculum, quality of teaching and learning environment in general? So actually, this has been one of the most gratifying things about all of it, is the students are so incredibly thrilled. I would just say that I've had students who actually struggled that first year because it's so much. And I offered to, free them from TCC, and they were unwilling because TCC was their favorite part of the whole deal. Like, they loved how patient-centered it was, how in the community it was, how they were getting real activities that they could link their learning from pathways, the rest of their traditional curriculum to. So, and those students have all done really well. In fact, one of those students has now won a grant and will be screening people in the homeless shelters and individuals experiencing homelessness for HIV and high-risk sexual practices in our community. So he will be making a difference in like 5 seconds. And he is one of those people, struggled early, but has just continued to grow. He's got that grit, and I'm so glad that we recruited for that. And there's so many of them that just don't want to give it up because they love their preceptor, and they love working with the nurses, and they love the interprofessional aspect. And they love working with the big team of residents that they know they're going to be a team member for a good number of years. So I think it really is a positive experience for them. And we get a lot of really positive feedback. I think, I really expected there to be a lot more pushback than there has been. And, these guys really have a lot of expectations on them. They have to do regular reflective essays. They have to keep patient logs. They have to write about quality improvement thoughts and social determinant thoughts on every patient. It's a lot that we expect them to do. And as I see them growing into the future interns that they'll be, I know we've done the right thing when I see them doing these big community projects.
I also think that they seem to be less burnout than other medical students, because they're really not focused on grades or their board scores or getting into their residency. They're actually just kind of enjoying their clinical experience. So they seem much more relaxed. It's also kind of nice to see the impact that it has on our clinic, because our residents, know that these are going to be their future, interns. So they spend considerable amount of time pushing them up very high in their clinical skills. So they really feel committed to the student population. So there's also just this, really amazing bond because they have that continuity and a longitudinal piece between the students and the residents, which I think help really improve the just morale and culture compared to other medical students that often are, in different rotations, worried about their tests. They're more engaged in clinical work and pop health work.
And I think it goes back to what I was sharing too with some of the slides as far as the TCC students are helping to also drive the residents to learn more, to be more active in the community pieces too. So it's really that every single piece of the puzzle of the team is working to make the team better, whether you're a TCC student in your first year, second or third year, or whether you're a first, second or third year resident, everybody's driving each other to really make the entire office better. And that's really a neat thing about this.
Oh, that's a really good question, Kevin. Yeah, that is, so Kevin Heckman asked, I'm curious how you would suggest scaling this approach to a larger number of applications. If you're looking at 600 right now, could you scale it to the 6,000 who apply? How would I do it? So I've actually been charged with that. That is coming. And I think that a good part of it could be done through looking at those situation judgment tests and the scales. We are still doing research on the scales to see what things stand out as predictors. We may reduce some of the scales to the most predictive questions. And that would be then easy to create an algorithm for, which is one of the things that, again, I've said I'm charged with working on. The other thing that we're charged on with working on is to expand and scale this program, which really it's about getting those residency partners. I can't imagine that there will be residency partners that are as engaged as these two. And, I think it's possible. It's all about finding people with the same mission. So I think if we can find those mission-driven places that it would be possible, but it's all about having them engaged also with the process. So, the additional output for me would not be so great as it would be in those places. And it is those first 2 years where you're doing, or 3 years, where you're doing both your regular residency interviews and these interviews, it's big. But now there's payoff. And it's payoff both in the program, the way it functions, and the interview process. So, I think it is possible. There is a cost, a pre-cost to the programs, but totally possible. A good deal of what we're doing could be automated. So last question that I saw was, will COMLEX 1 go pass fail? And I've left that for last because while I like to think I'm a prophet, I'm not actually part of the people that make those decisions. So it would be my guess that the answer is yes, it will go pass fail eventually. I think that USMLE and COMLEX have come much closer together over the years in terms of their processes. And I'm thinking that the answer is probably yes. In fact, I'm surprised COMLEX 1 didn't go pass fail before USMLE because, allopaths. I can say that.
Yeah, I think we don't know for sure for COMLEX, but maybe going the same route as USMLE is probably the route they'll go. So.
That looks like all the questions. So.
Great.
Elenetta, if you had anything else?
Sure, thank you. Thank you all. And I guess if there are any sort of final comments that you would want to make, especially for our programs that are currently struggling with the recruitment process and not having those usual metrics and wanting them to maybe consider a more holistic approach. Are there any sort of final takeaways that you want to share with our audience?
I think the biggest thing is that as we as a healthcare community and people that are interested in caring for others, as we want to improve outcomes for society, for our patients, one of the big things is that we need to have a workforce that represents our patients. And so I am incredibly committed that we need more Black doctors, especially Black male doctors. And so one of the things that we need is that really comes from someplace. You have to put energy in to get that. It's a decision you have to make up front, and it will never happen without a lot of, like-minded individuals. I always feel like this is my community, and I would like to see that community look like the one that I live in. So I would really encourage you to put your heart into this. It has incredibly big payoffs, because as we have a more diverse team, it impacts everyone. Our entire team has changed. And I just cannot emphasize enough how important that is. And, we cannot be looking at things like numbers to make those decisions. Some of those numbers are wrapped up in long-term social determinants that, like they've impacted our patients, also impact people's ability to get where they need to be. And we need those folks in our programs. So I encourage you, and please reach out if you need help there. Okay.
I was just going to say, if you have any other questions that come up later, just please make sure to take down either any of our email addresses and reach out to us. We'd be happy to share anything. And even if you want to wait another year and chat with us whenever we have our third year class of TCC students become interns, as we move from that UGME world into the GME world or UGME, we're going to definitely see where that takes us as that first class moves into that next stage of the process.
Yeah, some of my thoughts are, to try to make make virtual recruitment fun, try to use some creativity. And I echo what Dr. Chrisman-Khawam also says is try to change your metrics. I really think this is the time, for us, during COVID, I think we actually flipped our clinic in one day from seeing patients to going virtually. We manned a nursing home, we did an inpatient care. And I think a lot of it had to do with just the fact that we had such a diverse team. So really trying to, maybe use this opportunity in your virtual interview process. A lot of times we might not even have COMLEX 2 scores, and just looking for different metrics and trying some creativity and getting a workforce that parallels the communities you serve, and then also, really figuring out what works in your system. And again, feel free to contact us with any questions.
Thank you so much for sharing this very innovative model, for all your perspectives, and for your inspiring commitment to diversity. We also want to thank everybody who joined us today. We know that this recording is going to be very popular, so we're going to make sure we post it very quickly to our AOGME web pages at acom.org/AOGME. And if anybody has questions, please contact us directly at aogme@acom.org. With that, this concludes our webinar. Thanks again to our speakers and to everyone who joined us. Have a great evening and a great weekend.